Got us a patho review here for our first exam. Let me see. Can you guys hear me okay? I get like a thumbs up or something or something. All
I hear you.
right, thanks, Anna. Okay. So I kind of want to start off with some review of the flow of blood throughout the heart because I think it's pretty important in understanding, um, the pathophysiological concepts where things go wrong, what's it going to affect. So I figured we could hit a little bit of a review on that. So starting it off here, through which part of the circulatory system does blood return from the body?
Vena cava.
Yeah, it's going to be, I was fancy. I threw in the plural term because we have a superior and inferior vena cava, vena cavae for plural. So yeah, blood returning from the body comes back through those large vessels. Which of the following separates the right atrium from the right ventricle? We got the AV valve, tricuspid, mitral, and septum.
Tricuspid.
Yep. Which of the following is inaccurate regarding blood flow through the heart?
D.
Right. That's the only place that I'm aware of in the body where it's the opposite. Anywhere else in the body, the arteries are flowing away from the heart, which they do with the pulmonary arteries. But the big difference is these arteries are oxygen poor because they're going from the right side of the heart to the lungs to pick up oxygen to come back to the left side of the heart, which brings blood out to the body. All right. Which of the following describe the filling of atria and ventricles during the relaxation period of the cardiac cycle? Is it systole, asystole, diastole, or the ST segment?
Diastole.
Yep. So systole is going to be when our heart's contracting and ejecting blood. Um, Hopefully, we'll get lucky and maybe never see an asystole. There's literally nothing going on as far as electrical activity in the heart during that. And our ST segment, as Jen talked about, is kind of like um, the relaxation period of the electrical portion of the cardiac cycle. All right, so let's list the entire pathway of blood through the heart. Um, I don't know how good you guys are with this, how good you feel about it, but for maybe some of us who are not, it might be good for them, and it's even good just to rehash it out, drive it in, and drill it. So let's start with blood coming back from the body.
Inferior and superior vena cava
Yeah,
into the right atrium.
give me my text box. I wanted to write it out. I'm blowing it. Okay. So we'll do IVC for inferior vena cava and SVC for superior. And then you said right atrium.
Yes.
So we'll do RA for that. And then,
Through the tricuspid valve
okay.
into the right ventricle.
Right. All right. And let's see. Peyton, I want you to tell me where we're going next. I'm putting you on the spot. Come on, Peyton, I need help. So mitral is going to be on the left side of our heart. So before we even leave the right side of the heart, we're going to go through a different valve, and it has to do with the lungs. I like the technical term of the lungs.
That's a
So again,
semilunar um, pulmonic
yeah. So um you could say semilunar pulmonic valve, or I don't think we have to write out any terms, but I like to keep it simple, pulmonic valve, because that directly relates to the lungs. But we have to remember that the valves that are between our atria and ventricles are AV valves. That's why they're named as such. A for atrium, V for ventricle. So we have our AV valves, and then I believe it's just simply based on um, the shape of the valve is why our aortic and pulmonic valves are called semilunar. So we've went through the pulmonic valve, so we're going to go to the lungs next. And actually, I'm sorry, I skipped a step. After we go through the pulmonic valves, we'll be in the pulmonary what?
arteries.
Right. And it's important to remember that these contain deoxygenated blood because it's just come back from the body where, the tissues and cells in our body have taken up that oxygen, exchanged it with carbon dioxide, coming back to the heart. It's oxygen poor. So lungs. And then where are we at now?
It's going to come back in through the pulmonary veins.
Yes. Okay. So we've come back to the heart. We've come full circle, so to speak. So where are we going to be now? Right, left atrium. I always try to remember atriums are like rooms. They store the blood until it goes into the ventricles so they can be pumped out. So now that we've been through the left atrium, where are we at now? Yep, mitral. Okay, we're narrowing it down. What's next? Can you guys see the chat box when I open it?
Yes, Brian's
Okay.
answering.
Okay, I kind of mixed up these abbreviations here. Forgive me. Yep, then aortic, and then we're starting back over. It goes out to the body, and then cycle repeats itself. All right, which of the following is the correct pathway of electrical conduction in the heart?
D.
Almost, Anna. You got two of them mixed
Oh, it's
up.
C. It's C.
It's going to be C. Yeah, we go SA. Um, I think Jen said, like, think SA, S as in starts, I believe, and then AV node. Then we go to the bundle of His. Those branch off into bundle branches. And then lastly, it terminates in the Purkinje fibers, which go down to our ventricles. All right, which of the following is the correct way to calculate cardiac output?
A.
Do we agree? I don't know. I don't think they agree with you, Anna. Yeah, it's stroke volume times heart rate. As far as I know, stroke volume divided by heart rate, that doesn't tell us anything. Maybe it does, but it's beyond, I think, what we need to know at this point. What does C tell us?
The map.
Yep, it's our mean arterial pressure. And then D, I'm sorry I didn't explain the term systolic blood pressure minus diastolic blood pressure.
That's a pulse deficit or
Pulse pressure.
pulse. Yeah, pulse
Yep.
pressure.
Okay, which of the following factors increase preload? Select all that apply. So what do we think about hypertension?
Yes.
I would have thought so, but I guess it doesn't.
Oh, because it's constricting the vessels.
Right. So I think if anything, that would decrease preload because that's less blood that's easily
Mm-hmm.
flowing, returning to the
Mm-hmm.
heart. Because we got to remember preload is the amount of stretch in the heart when it's filling.
That's right. During diastole.
Right. Correct. So what do we think about vasoconstriction? You can kind of lump that in with,
Hypertension.
yeah, similar. And then vasodilation.
Yes.
I would think
Wouldn't it? Well, okay, now I'm confused.
so. I don't know if necessarily opening up the blood vessels is going to increase the flow potentially. I got this from Evolve and it said not. So, I mean, it didn't really give me a solid rationale as to why. I mean, you can definitely argue that um, afterload would be decreased with vasodilation
Right.
and it would be
Right.
increased with vasoconstriction. So,
But it
I don't
doesn't
know.
necessarily affect preload, so it's going to be D and E.
Right. Because those directly, there's a volume increase. With D, it's a total volume increase, which is you know, gonna be more filling during preload and hence more stretch in the heart. And cardiac valve regurg isn't a total volume increase, but if we have a backflow of blood from the ventricles to the atriums where we are filling, then there's going to be added volume because not all of it is getting out
That
when the
makes
heart
sense.
pumps. So this one will be D and E, and I don't know. I don't know about C. Doesn't say anything specifically. So, which of the following describes what is heard with an S1 sound when listening to the heart?
Is it B?
You say B is in boy?
Yes,
Yep, that one is correct. So, what about our S2 sound?
that would be C.
Right. Because we got to think, it seems sort of strange, but when the ventricles contract, it puts pressure back onto the valves that are between our AV valves that are between our atrium and ventricles. So that forces them shut. And then after that, blood is pumped out. Blood is forced through the semilunar valves, being the pulmonic valve and the aorta. And then once our heart relaxes, those close, creating our S2 sound. What effect does increased activity of the parasympathetic nervous system have on the heart?
A?
Yep, so that's going to decrease our heart rate, which, um, heart rate and stroke volume create our cardiac output. Blood pressure is determined by cardiac output and peripheral vascular resistance. So I'm sure you could say the same that blood pressure would be reduced as well. Yeah, because sympathetic activity increases our heart rate and increases our blood pressure. Which action does the nurse take after noting the following assessment? Regular heart rhythm with a rate of 60 beats per minute, a P wave preceding each QRS complex, a PR interval of 0.20 seconds, blood pressure of 118 over 68, respirations of 16, and a temperature of 98.8. So, is there anything really concerning there?
No.
No, we good.
C.
I'm
But I like your
disappointed.
D answer.
Yeah, good choice, Eddie. Yeah, so
It's not wrong.
going back, our normal heart rate is 60 to 100. We want a P wave before each QRS complex. What's our normal range for our PR interval?
0.12 to 0.20,
Right. And then what about our QRS duration?
less than 0.12.
Right. And blood pressure is good, respirations are fine, and temperature's fine. So yeah, just keep an eye. All right, what's the rhythm and rate? And you start from the first box to the last line. So just simple counting. I know I'm no good at math, so
In the 120s, regular.
yep. So relatively from what we can see, our QRS complexes are evenly spaced out. Yeah, it'd be normal sinus. We have a P wave before each QRS. So yeah, we'd be sinus tach. Okay, which of the following are potential causes of sinus tachycardia? So do we think stress could raise our heart rate?
Yep.
All right, what about trying to poop real hard?
No,
No. And then gagging.
I don't think so.
All right, so what about fever
Yes,
and pain?
yes.
I mean, yeah, you could really associate pain and stress together, sort of. But gagging, no, that's more likely to cause a vagal response, which will decrease our heart rate and put us in sinus brady. So the correct choices here are stress, fever, and pain. All right, so I don't really care about what the rate is. I think, well, actually, this picture I found, it doesn't give us 30 blocks because we need 30 blocks, right, for um, 6 seconds worth. So um, just looking at the rhythm, what do you think we're dealing with here?
Is that AFib or is that a flutter?
So let's talk about well, our big atrial dysrhythmias, AFib and flutter. What's one of the big things that helps us determine that we're in an atrial dysrhythmia?
You can't decipher a P wave. The QRS is normal.
Right. So the big thing is that there's no discernible P wave, and a lot of the times with AFib, our QRS is irregular. It's not very neatly spaced out. With a flutter, again, we don't have a discernible P wave, but um, the electrical activity before the QRS complexes is like a sawtooth pattern. So it looks kind of like a saw, and that is more of a regular looking rhythm. So those are big
So this is
distinguishing.
AFib.
Yes, because we don't have the discernible P waves. It's not that kind of neater looking pattern, and our QRS complexes are irregular. Where an atrial flutter, again, no P waves. It looks more regular, especially the QRS complexes.
Okay. That actually helps a lot. I've seen a couple of them that I thought they had to have been fib because they didn't have just like that obvious sawtooth appearance.
Right.
But apparently they were A flutter, and I couldn't figure out how to differentiate between the two because sometimes the A portion of it looks, or the P wave that's not there looks similar,
Right. And I
and it's
was
hard to tell. They're both chaotic, but one's more um patterned chaotic.
right. And honestly, with what we are given, we're giving picture perfect rhythms, which luckily, fortunately, throughout nursing school, Yeah, I'm sure with the NCLEX we'll get like the perfect examples. But I was in the ICU last week, and I had the tech print me out a strip of atrial dysrhythmia, and I thought it was AFib, but it was flutter. And what he taught me was to trace um, each P wave before the QRS to the next P wave, and like you can trace it like a hump directly to each. Like it looked like this. I thought it was atrial um, AFib, but it was actually a flutter. But it just
But
goes
the
to show
QRS was more, what is the word I'm looking for? Patterned.
it looked regular to me. Yeah,
Hmm,
so I figured it was flutter, but like I said, luckily we get picture perfect examples. What is it?
VTAC.
I thought about screaming, but I don't know who has headphones on. That's probably not professional. Okay, so I guess I meant to ask it before. I mean, it's kind of beyond what we need to know for Monday because we're just looking at the patho, not really the nursing interventions, but um, tell me about some like with AFib or even flutter, what's the biggest complication that we're concerned about?
VTAC.
All right, we're back at AFib. So I mean the biggest complication with AFib.
Stroke.
Oh,
Right,
clots.
exactly. Because that those atria are quivering and blood's not flowing properly to the ventricles a lot of the time. So you get that pooling and potential clotting. So
Right.
big thing, our patient's going to need to be on anticoagulant therapy.
Anti-coax.
Right. And then as far as drugs for rhythm control, what might these patients get? Right.
Are we
Calcium
talking
channel
about,
blockers are huge. Yeah, like the drugs we would give for rhythm control. So calcium channel blockers are a big one, which I know, people can take um cardizem and the other ones at home. I don't know about amiodarone. I don't know if anyone can shed some light on that, but that's another one for controlling the rhythm. I don't know if that's
I don't think that's something that they would send as a home med. I think that's just like hospital use and
right.
initial onset of AFib.
Okay, yeah, because yeah, the what's our long term like if someone takes amiodarone for too long, what's the big thing we're worried about?
Pulmonary something. Pulmonary issues.
Holy shit, Anna, you came in hot.
I know,
Pulmonary
sorry.
tox,
I
is
was
it
like trying
pulmonary
to think
tox,
about it.
Yeah,
pulmonary
Sorry.
tox,
it's
and
pulmonary. You're
ultimately
good.
pulmonary fibrosis?
Pulmonary toxicity, yeah, which
Thank
Right.
you.
thanks, Anna.
Hey,
Thanks for
number
waking me
three.
back up.
No, I know. Sorry.
Okay, so now going back to VTAC. If we see VTAC on a monitor, I guess any, potentially lethal dysrhythmia, what's the first thing we're gonna do?
Assess your patient.
Yeah, check them out. What's going on? How you doing, buddy? And particularly with VTAC, what's the big assessment piece we want?
Whether they
Pulse.
have a pulse or not.
Right. So let's say they don't have a pulse. Besides shitting your pants, what are you gonna do? Yeah. So they're gonna need defib. So what about if they
Addie,
do
you
have a
crack me
pulse?
up.
We use a cardio version?
Right. Yep.
Yeah.
Cardioversion's the big thing with stable VTAC versus unstable. What?
But an ST depression?
Nope. Strike one.
PVCs?
PBC.
Yeah.
Okay. Okay, we're on to something. What type of PVC?
Damn.
Ventricular.
Right.
Well, PVCs are
PVCs
premature
are ventricular.
ventricular complexes, but
PV. Yeah.
Bifocal
You can.
or multi?
There's PACs.
Oh,
yes,
multifocal.
multifocal.
Addie.
Because we have two deflections here. We have the positive with the first
Oh.
one and then a negative deflection. If you're just seeing,
I
which I don't
didn't see
think
the
it's,
other one. The chat box was covering it.
oh, sorry. I don't know how, if we really need to know multifocal versus unifocal. I
We
just thought it
might.
was cool.
It-
Um, so a lot of times with PVCs, they can resolve on their own, like caffeine, alcohol, stress, like us normal, young, healthy people can experience these. But when it's sustained and too frequent of PVCs, um, they really just try to eliminate the cause. There's really no, I don't really think they use any kind of meds for it or cardioversion. Like low magnesium and cal or potassium can cause it. And just like, if you're drinking too much caffeine or smoking too much or drinking too much, you try to eliminate the cause. But PVCs are huge after someone has an MI and they're pretty typical, but it can be an indicator that they might deteriorate. So some food for thought there. Which is the priority after a crash cart has been brought to a patient's room where the nurse is responding to a patient in ventricular fibrillation?
B.
Speak up.
Is it
B.
B?
Yes, it is B as in boy. So remember that VFib gets the DFib. All these other things, could be done, but priority is DFib. Same with pulseless VTAC. Shock them.
B gets the D.
Yeah. Which cardiac rhythm typically deteriorates into VFib?
Is it C?
C.
Yep. Yeah, it is. From what I understand, VTAC's a ventricular dysrhythmia and it has the potential to become unstable. A flutter is an atrial issue, and supraventricular tachycardia is. I don't really truly understand how it works. I know there's like a re-entry mechanism where the atria are firing and it's like bouncing back and forth, but I don't know why. Well, supra means above the ventricles, so yeah, it's the
Right.
atria that are causing the tachycardia. So,
Yeah,
I-
she said it literally. It's like the electrical impulses, instead of going in normal order, are literally going from SA to AV, SA to AV, and all the fibers in between.
right, yep. So, yeah, I guess with that, it makes sense. When caring for a patient with heart disease, the nurse identifies that which action may lead to serious Brady dysrhythmias. Why? Yes, very good. So we talked about it before with when we looked at the question with causes of sinus tachycardia. On the other side, it was gagging. So if you're doing oral pharyngeal suctioning, you could stimulate the gag reflex, which can then stimulate a vagal response, which can give us bradycardia. Which of the following would indicate a positive effect of atropine?
D.
Good, good. So what would we give atropine for?
Bradycardia.
I'm just making sure. And then, so yeah, Jen said A to the T to the top for atropine. So then adenosine. What do we really give that for usually?
Tachycardia.
Right, but which type of tachycardia?
SVT.
Yes.
Thank you.
Woohoo!
You don't need to thank me. You don't get any points from this. You're not getting a grade, but
Okay, I get points in my mind, Joe. Thanks.
no problem. Just letting you know. But yeah, I kept getting this mixed up for a while until I had to talk to Jen about it because I thought they'd give it for VTAC, but they really only give it for SVT. Okay, which risk factor is known to contribute to AFib? Select all that apply. So what do we think about palpitations?
Yes.
Okay, what
Wait,
about
was that an answer or a question?
Is that I'm like not sure.
All right, well, let's keep moving forward. We're unsure. We're not certain. There's a little bit of uncertainty, but I like the delivery. It sounded like you meant it.
Kind
So,
of.
what do we think about advancing age?
Yes.
E. So, and what about boozing? Too much boozing.
That seems to be the cause of everything, that and smoking.
Yeah. So, what about use of beta blockers?
No.
No. And then hypertension. So, that one's a yes. I mean, pretty much hypertension's a risk factor for anything. So, more often than not, it's going to be a risk factor. But palpitations is no, because that's more so a symptom of AFib. People can have, like, if you have like an occasional PVC, you're too stressed out, you smoke too many stogies, you could get, a palpitation. And then
That makes sense.
advancing age, you lose some of the, like, your pacemaker cells and your heart doesn't respond as well. So can lead to more irritability, excessive alcohol use. Yes, that's known to cause cardiac irritability. If anything, beta blockers are going to be used to treat AFib. And then hypertension, yes, because it puts more stress on the heart. So this one's going to be B, C, and E. Which action does the nurse take first when a patient develops VFib?
B?
B.
Well,
Right.
actually, it would be D while somebody runs to get the B.
Right. In a perfect, in the actual situation, yes. But I know we kind of, we just answered this question, but Jen talked about how you can easily miss this question. If there were any other option
Yeah.
for B, like, start epinephrine IV, you're going to start CPR. But if
Yeah.
defib is in the equation, that's what you're going to go towards. If you're in the room, you call a code, start CPR, someone goes and gets the crash cart. But, for the purpose of testing, they want us to know, like, what is the priority? We need to, like, shock them out of this rhythm. What is a P wave seen on an ECG reveal? By the way, for those who don't know, I didn't
D.
know it until recently. EKG and ECG are the same thing.
Yes.
All
Which
right,
kind of
Joe.
sucks because an echocardiogram is also listed as an ECG.
Right. I do believe I had to look this up. If I recall correctly, EKG came from German, like electro, like it's spelled different, electrocardiogram or something, and then English makes everything easier, so that's why we changed it to ECG. So yeah, it's going to be D. That's when our atria depolarize. What on our ECG represents ventricular depolarization?
QRS.
Yes. And then what about ventricular repolarization?
T wave.
Yep, it'll be the T wave. And then lastly, the time for atrial depolarization of conduction of impulse to the rest of the electrical system. I don't know if that's something we really need to know, but it's an answer choice, and I'm asking you.
Is that the PR interval?
Yes. So PR interval is inclusive of the P wave, where the PR segment is from the end of the P wave to the QRS complex. So the PR segment really just represents the time it takes for the impulse to travel, I think, yeah, to the AV node where it's delayed, and then to the rest of the conduction system. Which again, I don't know. I think, Jen wants us to know what a P wave is, what that represents, what our QRS is telling us, and what our T wave is telling us. Which of the following laboratory tests is a reliable indicator of myocardial damage?
D.
D.
Yep, it's going to be our troponin because that's a enzyme that comes directly from cardiac tissue. I don't think well, I still see it in labs. They use CKMB, but musculoskeletal disorders can raise that. So it's not really reliable. We know that the troponin only comes from myocardial tissue and it's released when there's damage. So troponin is the gold standard.
Can I add to that real quick?
Yeah.
So that was my understanding, is that obviously it comes from the myocardial tissue and that it comes from damage, ischemia, heart attack, those kind of things. I didn't realize the troponin level can be raised so high for just inflammation and irritation. So we had a patient come into the ED on Thursday who their first troponin level was 2,500. And I guess normal is 0 to 54 according to Olean General. Their second troponin level 2 hours later was 8,500. So I was thinking, please tell me this kid doesn't have a heart attack. And it wasn't. They did an echocardiogram and it was pericarditis from tonsillitis he had like a week and a half ago. But I wasn't thinking that because I thought it has to be actual damage for the troponins to be released. And Jen clarified for me that it doesn't. Even just inflammation, anything involving the heart, the pericardium, the endocarditis, the pericarditis, whether it's infectious or not, none of that matters. All of those that affect the heart and put strain on the heart can release
Yeah.
those troponins.
And that is the key word. Like anything that puts strain or stress on the heart can elevate the troponin. But when we're looking for damage, that's what we're looking for, which I mean, it's good for you to clear that up because I mean, you could be, at clinical or in the hospital and you see a troponin and it's going up and you're like, shit, they're having an MI. Like we got to do something, but you got to look at what else is going on too.
Right.
Because when I was a phlebotomist, I used to tell people if their troponin was up, like I learned what it was, but I didn't tell them that this means you're having a heart attack. I said it means there's stress on your heart, and that's how your heart's responding.
Perfect.
So
Perfect. Well, and this was a kid who's had really big cardiac history in the family. Like mom had a confirmed heart attack at 42, sister had a confirmed heart attack at 21. So that's where he woke up in the middle of the night with horrible chest pain, but he had all those pericarditis symptoms, or like when he was laying down, his heart pain was worse. When he sat up, it was relieved. All of those things that they told us to watch for it. Sure enough, he fit every single one of those.
Yep. Yeah, it's a good example of how, certain things can be reflected by something else. But all right, so true or false, the right side of the heart commonly fails first.
False.
Right, it's going to be the left side. And I can't tell you why, aside that, a lot of systemic complications like hypertension, they're big contributors to heart failure along with coronary artery disease, where with the right side of the heart, well, once the left side fails, the right's coming next. But for the right side to fail initially, it's usually as a result of a pulmonary condition. Which condition does the nurse suspect in a patient with heart failure who expectorates frothy pink tinged sputum? Yeah, this one's going to be D, pulmonary edema. And which type of heart failure do we usually see that with? Right. The nurse monitors for which symptoms of poor tissue perfusion in a patient with heart failure. Select all that apply. So the big thing is we're looking for symptoms of poor tissue perfusion. So what do we think about fatigue?
Yes,
Yeah, and then cyanosis.
definitely.
Yeah, weight gain.
No.
No, and then cool extremities,
Yes.
and then JVD, jugular vein distension.
No.
Right. So really with poor tissue perfusion, it's an issue with the blood getting where it needs to go. So, for our musculoskeletal system, if we're not getting enough blood to our muscles, we're going to be more tired, we're going to fatigue easier. And then along the same lines, we can see cyanosis, the blue discoloration from not enough oxygenated blood getting where it needs to go. Weight gain and JVD are more of an issue of venous return. That fluid's getting backed up. It's not getting back to the heart. And then cool extremities, you're not getting that warm blood out. So it's an issue with perfusion. The nurse is caring for a patient with heart failure. Which lab test would the nurse expect to be elevated?
A.
A.
And what does that test tell us?
The ventricles have been stretched, overfilled, heavy fluid.
Yes. So this test is a big indicator for heart failure, and it's also huge. If we have there's so many patients who have cardiac and pulmonary problems. So someone comes in with acute shortness of breath. Um, we're trying to figure out if it's cardiac related or pulmonary. This test is a huge um, you know differentiating factor in determining what the actual cause is. The nurse monitors for which cue in a patient with heart failure. Select them all. Just pick all of them. So, what do we think about fatigue? I think we already talked about this. So,
Yes.
yeah. And then tachycardia,
Yes.
C,
Yes.
E, and then D.
Yes. Yes.
And then E.
No.
Right. If anything, we see that frothy pink tinge sputum. That's the classic finding. Thick yellow sputum would be more so with infection. Now, Anna, I'm calling you out. I'm calling you out, dog. I want you to read. I want you to look at D again because I missed this one, and it's so easy to miss.
Uh, no, they usually sleep with multiple pillows.
Yes. Yeah. I don't know. It's just like I don't know if it's like reading it too fast or what, but yeah, it happened to me too when I took this one. So it's going to be A, B, and C. Um, fatigue, we already talked about that with the poor cardiac output, tachycardia, our heart's trying to compensate to keep up, to pump more out. And then with our heart trying to beat more, that creates more of a demand for oxygen in the cardiac muscle tissue. So then we can see symptoms of ischemia. And then a lot of times they sleep with a bunch of pillows. Okay, true or false? A patient with an ejection fracture below 50% is considered to have heart failure.
False. I think it's below 40.
Shit, yeah, I
It's,
think you're right, but I guess the sake of this
but
question
60 to
is
70 is normal.
50 to 70 is normal. And
Okay.
that nurse's labs video, with that one guy, he said 55 to 70, but Jen has said 50 to 70. And then, I remember that because we were talking about the amount of blood in the body, and that's 5 to 7 liters. So for some reason, I like paired those together, the 50 and 70, and then 5 to 7. But yes, I think the actual diagnostic criteria is an ejection fraction below 40. But I kind of put this question in so we can remember what's normal, which is 50 to 70. So, which of the following characteristics distinguish left sided heart failure from right sided heart failure? Select all that applies. So, we're really looking for the symptoms of left sided heart failure. So, what about increased venous pressure and volume in the systemic venous system?
No.
Right. We'd see that with right sided. And then pulmonary congestion.
Yes.
Yes. Because we got to remember if the left side of the heart's failing, we got to think about where that blood is coming from to the left side. It's coming from the lungs. So if our left side's failing, it's not putting enough out. That's going to put more pressure on the lungs because that's where the blood's coming from. So then we get all clogged up because the blood's not getting out from the left side. And then C, yes, because our left side of our heart is what pumps blood out to our body. So if that's not functioning, we're going to have decreased tissue perfusion. And then peripheral edema, no, we'll see that with the right side. And eventually we'll see right ventricular hypertrophy as the right side is trying to start to compensate from the issues of the left side, but that's not really until later. So this one's just going to be B and C. The other symptoms are going to be right sided. Which characteristic of heart failure would the nurse associate with malfunctioning of the left ventricle? I don't know what you're trying to say,
C.
Addie, but it makes zero sense. Okay. Yeah. As I just gave my long winded explanation of the last one,
That's right. Can blame it
it
on the
fell
dog.
on the keyboard. Yep. So if the left side's not functioning, it's going to back up in the lungs, simply put. Okay. True or false? Pulmonary disease may precipitate right sided heart failure.
True.
It is true. I like I don't know, you put some jazz on that, true. Sounded like you really meant it. So, yes. Which of the following signs and symptoms would present in an individual with right sided heart failure? Select all that apply. So, what do we think about weakness? Okay, and then pulmonary congestion,
No.
right? Peripheral edema, yes. And then nausea and anorexia, that'll be a yes. And then dizziness, that one's going to be a no. And then hepatomegaly, which is enlarged liver, and then splenomegaly, enlarged spleen, that'll be a
Yes.
yes. So A is actually incorrect, and I'm guessing that's because of with left-sided we have the decreased tissue perfusion, which leads us to the weakness, which I would think, if the heart's failing, eventually we're going to lead to weakness, but it's not a typical symptom with right-sided. We talked about pulmonary congestion with the left. See the peripheral edema, problems with the right side of the heart, which is blood coming back from the body. So if the right side of the heart is not getting the blood out, it's going to back up into the body. The nausea and anorexia, I believe that goes along with the enlarged liver, particularly. The liver gets enlarged, can put pressure on the stomach, and then you get anorexia and nausea, I guess, associated with that. Dizziness is that decreased cardiac output. Um, so we're not maintaining our pressure. And then, the liver's in pretty close proximity to the heart. So blood's getting backed up from the heart to the liver. It's going to enlarge. So, which of the following is the best tool in diagnosing heart failure?
C.
You say C is in cat?
C is in cat, Joe.
Thank you. Yeah, it's going to be our echo, which we can use that to determine our cardiac output and ejection fraction, which is, like Jen said, people with renal failure, they know their GFR. People with heart failure, they know their ejection fraction. EEGs, brain scan. I think we're pretty familiar with the other stuff. All right, true or false? The compensatory mechanisms that act to increase cardiac output in heart failure have a damaging effect over time.
True.
It is true. All right, so let's talk about it. Let's have a discussion, a discord. What are these compensatory mechanisms? I even gave you a hint.
So the
There's
RAS and the sympathetic nervous system
and
stimulation.
isn't there parasympathetic nervous system too?
It's not one of the compensatory mechanisms.
Okay.
Right.
Stimulation of the sympathetic and the RAS.
Okay, so we got sympathetic, added chemical, and what's that last
And
one?
hypertrophic uh was it
Yep,
hypertrophic cardiac
you hit it.
ventricle?
That's the result of it. It's ventricular remodeling.
Yeah, that one.
So first, our sympathetic, that's the most immediate response, is a sympathetic stimulation because we have decreased tissue perfusion. So what that does is it jacks up our heart rate, causes vasoconstriction, increasing blood pressure. And the thing to understand here is the only thing that the body is recognizing is that blood and oxygen is not getting where it needs to go. It doesn't realize that the issue is like pump failure with the heart. So as heart rate increases and the vasoconstriction, the blood pressure goes up. Blood pressure increases our afterload, which is, the force the ventricles need to overcome to push blood out. So that creates more work on the heart. And as the heart rate goes up, that creates more demand as well. So when the heart's failing over time, that's going to be damaging. And then with the RAS, that's our renin angiotensin aldosterone system. So, the angiotensin further contributes to vasoconstriction, raising blood pressure. We're just the body's saying we're not getting enough blood flow to the kidneys. It doesn't realize that the heart's the problem. So, um, Then with the aldosterone, sodium and fluid retention increases, which you can look at that as more of kind of like fluid overload. So that's more preload on the heart, which creates more stress. Um, there's like, I don't know, I think there's like tumor necrosis factor and all this other shit for the chemical response, but the only thing we really need to know is BNP, which is the heart, saying I'm being stretched out too much. Let's piss out some fluid. And then the ventricular remodeling, the heart tries to build more muscle tissue to pump adequately, but more muscle means more oxygen is needed to work. So the source of a patient's dysrhythmias and heart failure have been attributed to a malfunction in the heart's ability to contract. How would this type of failure be described?
A.
Right. And I think the key word in this sentence is ability to contract. If it listed the symptoms of like, let's see, the source of a patient's symptoms from heart failure, I don't know. Um, if it said something about along the lines of like the pulmonary congestion and decreased cardiac output, fatigue, you might be able to say, well, that's left-sided heart failure, but we're talking about pump failure here. So there's the two broad types of heart failure: systolic, where the heart's failing to pump adequately, and diastolic, where it's not relaxing enough to fill adequately to pump out. And then you can further differentiate that between left-sided and heart-sided. All right, which factors produce systemic arterial blood pressure?
The D.
It is D. And I thought it was really nice to include this one because it's so easy. Like you can mix it easily up with cardiac output, which I mean cardiac output is the amount of blood the heart's getting out in a minute. And this is really just our pressure. I don't know if we'll see a question, but I think it's good to look at. So yeah, our stroke volume and heart rate determine our cardiac output. Which factor increases the risk for primary hypertension? Smoking is no. That doesn't make anything worse, just makes everything better. Just kidding. So what about pregnancy?
Yes.
Okay, and what about kidney disease?
That would be secondary.
Yes. And then hyperlipidemia, high fats in the blood.
Secondary.
Okay, and then oral contraceptive use.
Yes.
Anna, you have failed. You've failed this question. I'm sorry. I love you, but you missed it. Um, so smoking is a yes, which I missed this one because I selected kidney disease, which is secondary, but pregnancy, like, people have preeclampsia or eclampsia during pregnancy. So the the hypertension is being caused by the pregnancy, which
So
it's
that
not a
would be so that would be secondary?
right. We're looking at
Okay.
things pretty much that directly impact our blood pressure. So we know that smoking and high lipids can raise our blood pressure. I don't know. Kidney disease really got me because, it affects our blood pressure, but it's an outside cause of the
Yeah,
vascular system.
yeah, exactly.
And then oral contraceptive use, that's secondary because it's something that's outside contributing to the development of a disease. So this one's just going
That's
to be
why that's why I would not have chosen D.
right. Yes, Addie, because I mean, there's primary causes of disease and secondary causes. There's primary hypertension, there's secondary hypertension. So I don't know, it can get a little muddy in that sense, but yes. Which patient is in the demographic with the highest prevalence of hypertension?
B.
Any other thoughts?
Addie said A.
Peyton, Ryan, I'm calling you out. Oh, Ryan's gone. She dipped. Peyton,
She bailed.
help us, Peyton. We need your help. This one's gonna be D. I believe it's up until 45, males are at higher risk, and then after it's women 65 and older are the highest risk.
Oh, I need to go back and look at that.
Yeah. Which I mean, I think that's one of the, because I feel like we know a lot about hypertension, what it is, what contributes to it, but who's most at risk is something that's easily lost. And I feel like that's definitely a question we could see Monday. So I thought this was a good one to put in. But yeah, if I'm not mistaken, I know it's six women that are 65 and older are at the highest risk, and I think it's men up until 45, and then it shifts. Which of the following is considered a medical emergency?
D.
Yeah, I was hoping that because anything malignant is bad. I would think um mal as in in Spanish, mal means bad. So I always remembered that early on. But I put in A because it's the same thing as primary hypertension. They also call it essential hypertension. They're synonymous terms. So what kind of pressure could we see with malignant hypertension or a hypertensive crisis?
Didn't they say like over 200, over like 130 or something crazy?
Yeah, to the 150s. It's stupid high. It's insane. Um, I don't know, gents. I think it says in the outline, which I don't think we talked about it in class, like the categorization of blood pressures. So I don't know if we need to, obviously below 120 and below 80 is normal, but there's two different classification systems in the book of what's considered pre-hypertension, what's stage one, and what's stage two. But just know when someone is above 140 systolic and they're like 80 to 89 or maybe like 90 or above, that's when like we're really considering like treatment. Aside from that, anything below, it's like start eating right, start moving around is the first step. Okay, which of the following is the primary cause of mitral valve stenosis? Yep, it's going to be rheumatic fever. And um, what do we see like? So there's infective endocarditis and rheumatic fever. They both have like, I don't know how to phrase it. What do we see in the heart? They're like these, yep, Ashkoff bodies.
Bodies.
Yes. And then with the infective endocarditis, what do we see with that?
Is that the vegetative
Vegetative lesions or something.
Yeah,
lesions? Yeah.
vegetations, vegetative lesions. Um, I kept getting them mixed up. I got these mixed up like with the rheumatic feet with rheumatic carditis and infective endocarditis, like which is which. But I thought both of them broke off. But I guess the Ashkoff bodies, they're just like like nodules that develop in the endocardium. And then the vegetative lesions break off. And then the thing we need to know about that is, do anticoagulants have any effect on those?
No.
No,
No.
right. Which of the following valvular disorders is considered a disease of wear and tear?
Aortic stenosis?
Yes.
Okay.
Yeah, as people age, I mean, you got to think about all the volume that's pumped through that valve throughout a lifetime. It's got to be in the millions, right? I know I've seen before how many times the heart pumps in a lifetime. I don't remember, but it's a lot. Let's just let's just say that. Um, Aside from that, I guess like rheumatic heart disease affecting the mitral valve can affect the aortic valve, and then yeah, just like degenerative like calcification of the valve contributes to it, but that one's the disease of wear and tear. Um, I don't even know if I remember. Does anyone know like what can contribute to aortic regurg?
Not for the life of me.
Yeah, I feel like maybe like hypertension would, but I can't say. And then I think with mitral valve regurg, with aortic regurg, I think like congenital structural abnormalities, which seems pretty straightforward, is like a big cause of it. And I think hypertension is too, but I don't know. Okay, which of the following are typical signs and symptoms of aortic stenosis? So what do we think about fatigue?
Yes.
Yep. And then pulmonary congestion,
Yes.
right? Because we're affecting the left side of the heart. And then dyspnea,
Yes.
yes. Peripheral edema,
No.
no, right? Because we're on the left side of the heart. And then peripheral cyanosis,
Yes.
yeah. And then syncope occurring on exertion,
Yes.
yes. So I had to change it because I went over this earlier and went and looked back at the text, and I guess the pulmonary congestion is more of a later sign. There's classic signs of aortic stenosis, and they come from something with cardiac output. Does anyone know the term I'm referring to? That's like big with aortic stenosis. Sorry, I feel like that's very vague, but I don't know how else to word it. All right. It's fixed cardiac output. Um,
Yeah.
so the classic signs and symptoms of aortic stenosis are the difficulty breathing, the syncope on exertion, and fatigue, I believe it might be worded differently. Um, but I mean, yeah, if you think about it with the syncope on exertion, our cardiac output is fixed at the same volume all the time. So anything that puts more stress in our body where there's more demand, our heart can't match the demand. So one of the big things with that is like passing out on exertion. You're creating more work on the heart, so it can't keep up. But once the left side fails, the right side will fail. Well, I guess that doesn't really matter. But the issues with the valve, eventually the left side's going to fail, which is going to lead to the pulmonary congestion eventually. Which of the following describe the valvular
Wait,
disorder?
so what was the correct answers for that
Oh,
question?
sorry. Yeah, this
It's
one's going to
okay.
be A, B, and B is like later as, the actual heart begins to fail. So fatigue,
That's a
pulmonary congestion,
late symptom. Okay.
right? The difficulty breathing, peripheral cyanosis, and the syncope occurring on exertion. So it's everything but D.
Awesome. Thank you.
Yeah. Okay, which of the following describe the valvular disorder of the heart where blood backflows from the left ventricle during contraction into the left atrium?
B.
Yep, it'll be mitral regurg. I thought this was a really good question for, I mean, this is really recalling like where which valve is. So, I mean, I definitely think, it's possible we could see a question worded like this, and it's really coming down to just remembering where which valve is. And on the right side of the heart, I guess, typically there's not really many disorders of the tricuspid valve. But it's kind of interesting to think of why it's always the left AV valve, the mitral valve, that's affected, like with the rheumatic carditis. Okay, true or false? Aortic regurgitation initially leads to right-sided heart failure.
False.
Right. It's going to be the left side because the left side is what's going to initially have to compensate to get that blood out. Which factor is the most common etiology of heart failure?
B.
Yep, it's going to be hypertension. Everything else is certainly a possible uh, etiology or contributing factor, but the big one's hypertension. And I was going through Evolve, and the same exact question popped up, but it was non-inclusive of hypertension. I don't know what the other answer choices were, but MI was one of them, and that was the correct choice. It was the same question:
Yep.
which factor is the most
I did
common
that one
etiology?
too, which it threw me off because I didn't select MI either. I
Yeah,
thought it was going to be something prior to that.
yeah. So hypertension, I mean, kind of makes sense. MI, if you have tissue necrosis, you know, that that tissue is non-functional after. Once it becomes scar tissue, it doesn't contract, it doesn't conduct electricity, so can definitely precipitate heart failure. Okay, the most primary cause of coronary artery disease is,
A.
yes, atherosclerosis. I figured this would. It's so easy to pick hypertension because it's like it messes up everything, it seems like. But yeah, the atherosclerosis, the development of those plaques, which, plaques break off eventually, can occlude an artery, especially in the coronaries, huge for coronary artery disease. Oh, look at that. I didn't. Which of the following are potential causes of aortic regurg? Select all that apply. So, rheumatic carditis.
Yes.
That was actually a no.
No, that
It's
one's
usually
no. Sorry.
non-rheumatic causes. Yep.
Yes.
Infective endocarditis. That was a
I think
yes.
so.
Yes. And then hypertension.
Yes.
Yeah, this is hypertension causes everything. And then I said it earlier, the congenital aortic valve structural abnormalities. Yes. Mitral
Yes.
valve prolapse is no. So this one's just B, C, and D. But I think it's important to remember with mitral stenosis, I'm pretty sure mitral regurg, and definitely aortic stenosis. Mitral stenosis and aortic stenosis, rheumatic carditis or rheumatic fever are potential causes of that. I think it is with regurg too, and I'm not sure, but this is the one aortic regurg that rheumatic carditis is not. And real quick, while we're talking about it, what is like the causative agent of like rheumatic carditis or rheumatic fever? What's the type of organism or bacteria?
Strep type A, group A.
Yes. Yep. Which term describes a lack of oxygen with angina that does not cause permanent damage to myocardial tissue?
A.
Yep, it's going to be ischemia. I always think like ischemia is like choked off, like it's lessened, it's closed, but it's not completely shut or
It's not
occluded.
dead yet.
Right. And then when necrosis, that's death. Infarction is a level of blockage that's likely going to lead to necrosis or death. And then obstruction, that's just I just threw that in there. Okay, which description of arteriosclerosis is most accurate?
Is
Would
this
be
one
A.
C?
Yeah, this one is C. Um, it's this one's easy to throw, yeah, because we learn about atherosclerosis, which I would
Oh,
think
that's
that could
right.
be between A or B. Which I
Yep.
got this from Evolve, and neither of those questions are reflecting atherosclerosis. I guess like it said like the fat deposits along the arterial walls, like it said something about fat embolisms. Because I mean, maybe it is, but like it didn't explicitly say so. But with this term arteriosclerosis, sclerosis means hardening or thickening, and then arterio being artery. So this one's just a term question. Um, yeah, atherosclerosis is like the formation of the plaques, which wait, so there's like an injury to this to the vessel, and then a fatty streak forms, and then plaque forms over it, and then it can
Yes.
rupture.
And it can, yes. And that plaque forming over it, in essence, narrows the vessel because it's taking up that excess space.
Right. Yep.
And then it can break off.
Thank you, Anna. All right. Which fact about unstable angina is correct?
B.
Yeah. So, I mean, I think when Jen talked about it was more so, well, no, it can occur at rest with her activities, but it's unrelieved and it's extended. If they rest or take nitro, it doesn't get better. And then with an MI, it evolves over many hours. What's the time frame between the occurrence of an MI and when physical changes are actually seen, like in the heart?
4 hours, 6 hours.
Yep, 4 to 6. So that's why it's really important to get prompt treatment and why they don't mess around when someone gets to the hospital with getting an EKG done or lab work.
Code STEMI.
Yeah. Okay, which change on an ECG or EKG is associated with the zone of necrosis in a patient experiencing an MI?
A.
Is it C, the Q wave for
Yeah,
permanent?
it's going to be the Q wave. With the T wave inversion, that's going to be our zone of ischemia, and then ST elevation is our zone of injury, if I
Oh,
recall
that's right.
correctly. And absent of a P wave, we see that with our atrial dysrhythmias.
So the Q wave is where necrosis has already occurred at some
Yes,
point.
right. Which is considered good cholesterol.
D.
Yes, or HDLs. All right. Which action results from the rupture of atherosclerotic plaque in the coronary artery? So, what do we think about necrosis?
Ultimately, yeah,
Right. The thing with it is, it's possible. It's not
yeah,
certain. Right. So that one's a no. Vasodilation,
no,
no. It'd be nice if it did, because that might let more blood flow
that might
through. But
help.
I suppose that's why we give nitro, because our body doesn't do it for us. That one's a no. Platelet aggregation,
Yes,
yes. And then thrombus formation of a clot.
yes.
Yep. And then atherosclerotic plaque formation. That one's going to be a no because that's what
Didn't that
led
already
to this.
happen?
Yeah, the
Yeah.
plaque formation already happened. It broke off, and now we have an obstruction. So, um, yeah, it's the platelet aggregation and thrombus formation because once that breaks off, the body sees it, activates the coagulation pathways, and it can worsen the clot. I think that's a big
Tries to
reason
fix
why.
itself.
Yeah, right. Which and that ultimately it worsens it because it'll occlude the coronary more. But I think that's why we give why we tell people to take aspirin when they have an MI. All right, which statement by the patient demonstrates the need for further teaching about the difference between stable and unstable angina? Sorry, I didn't tell you guys. We have two more questions left. Thank you for sticking with me here. Yep, it's going to be C. Um, the unstable angina can happen at rest too, and it's unrelieved. So I guess there is the possibility with ECG changes. It didn't say why. Um, not relieved with rest or nitro, unstable angina, that is true. And when it's stable, nitroglycerin or rest typically takes it away. But the unstable angina can happen with activity or without. Acute pain associated with angina is caused by decreased.
See,
Yep. Yeah, it's just oxygen getting to the myocardium and yeah, perfusion. It's not getting there. So yeah, increased preload and increased afterload, get rid of decrease caused by increased preload and afterload. That could certainly contribute to angina because it's putting more demand on the heart, but the issue is actually from oxygenation and perfusion. Okay, true or false, associated symptoms are a key differentiating factor between unstable angina versus MI.
true.
Yes, that's where we look for like the nausea, vomiting, diaphoresis.
Diaphoresis.
Yeah. And then lastly, I was going to put a question in earlier, but I forgot. There's a couple of terms that were included about myocardial tissue. There's four of them, and they reflect like what the capabilities of myocardial tissue are. I guess I'll give you guys one to start off. So one of them is automaticity. Do we know like what that is? Can we recall?
Is that the ability for it to automatically continue or sense the stimulations?
Right. It's the ability to automatically and repetitively or spontaneously and repetitively generate an impulse within the myocardial tissue. So now that we have that one, what's another one?
Contractility.
Yep. And that one's pretty straightforward. It's the ability of the tissue to contract, to squeeze. Okay, so that leaves us with two more.
Excitability.
Conductility.
Yep. So excitability, what does that one mean?
Are you asking me? Because I really don't. I just knew
So
it was one.
that one's the ability to respond to an impulse.
Okay.
So our last one, conductivity.
Is the
That one.
ability to electronically respond to impulse.
Well, that's it's easy to mix up. Excitability is be able to respond to an impulse. Conductivity is the ability to send or carry an impulse. So like if
Send or
you
carry.
right, if you think of it like
Carry.
metal's a conductor of electricity,
Okay.
so it can carry it. That's how I
So
keep it straight.
I'll just remember conductility, carry.
Yes. Make it as easy as possible. Right, guys, that's it. Thank you so much for coming.
Thanks, Joe.
Joe,
Enjoy
we
this.
appreciate you
We
so
always
much.
appreciate it so much. Send out the PowerPoint, please.
Yep, I
Please.
recorded it as well, so I will again post it on the YouTube channel I have. And yeah, I'll send out the PowerPoint as well. It might be tomorrow.
Wait, you have a
thank you,
YouTube
Joe.
channel?
Yeah, I made it last semester because I couldn't like post it to I couldn't get it to Brightspace or anything. So
Oh, I didn't even know that. Can you send out that link too?
yeah, absolutely. I'm going bowling here pretty soon, so I'll probably do it tomorrow.
In
But
the morning is fine.
yeah. Okay. But if you guys are watching the Super Bowl, enjoy. Please root for the 49ers because I don't want the Chiefs to win.
I'm hearing a lot of that.
Yeah. All right, guys. Have a good night.
Thanks, Joe. Appreciate you.
Yep. Bye.
All right. Bye. Hi, Addie. Go Chiefs.
She can eat. She can eat it.
Good night, guys.
See ya.